Good afternoon. At the outset, I congratulate Dr. Randeep Sood and Dr. Rajesh Puri for putting up this world-class show. We just had a very lively panel discussion, and we dealt with all the areas of tissue acquisition. But I'm sure there are certain areas which are still being sorted out, and there are certain novel areas towards which the tissue acquisition is moving. There can be no better person than Professor Peter Billman to take you through the entire journey of past, taking us to present, and then giving us insights into the future. It's my great pleasure to invite Professor Peter Billman for his lecture. Professor Peter.
Thank you a lot. Thank you for the opportunity to share this past with you as well, but also present and future of US-guided tissue acquisition. So the aim of my talk today is first to give you a historic background seen from a personal perspective, and in particular development of needles. Then I would like to go into summary of results from needle studies within gastroenterology, but also a little, just shortly, on pulmonology, because this has also been part of the development. And then future directions with FNA, with FNB, and through the needle microbiopsy. So when I started my interest, I visited LocTU in 1985 in Amsterdam. At that time, it was only radial scanning endoscopes. And at the same time, people thought that imaging alone would be enough to say whether a lesion was malignant or non-malignant. But there were no possibilities in obtaining tissue from a lesion outlined by US. The problem was that there were false positive diagnoses, and the diagnostic accuracy depended on the disease. That means that if the disease was very aggressive, a lymph node would most likely be malignant. So if it was not as aggressive, a lymph node would not necessarily be malignant. So I started with a prototype endoscope in 1989, in January 1989, and I got the first experience just with anatomical looking at the anatomy, which was not easy. And at that time, there were only 2 publications from the United States from 1980, concluding that the anatomy was too difficult and it was not for human use. When I got this in the beginning, I must admit, I thought he might be right. But we continued, and in 1991, we got a new endoscope after a close collaboration with Hitachi and Pentax at that time. And we started developing new needles for this. This is the image that you see is in a Danish paper. It says the inner ear. And this is a young me and my mentor, Søren Hanke, who was part of this development as well. I published the first publication in 1992 on US-guided FNA from pancreas. But we started with Cook in 1991 with plastic sheath, plastic catheters, long steel needles, and it didn't work. Then we got the idea to get to a long steel needle covered in Teflon sheet, and this was the way we actually got our first biopsies. We got the idea that sometimes the force translation needed some kind of connection with the needle on the inlet of the endoscope. And therefore we got in collaboration with Mediglobe to produce the first, this is a prototype handle, and then in 1995 the Hanke-Wilman needle, and now you know there are lots of needles on the market. Now they are single-use needles. The Hanke needle was only the needle was single-use, but the rest was multiple use. I defended my thesis in 1998 and published the first book whatsoever on linear EUS anatomy and as well development of EUS guided FNA. And part of this thesis was, how should EUS FNA be performed? And we have gone through this, but each of these steps are so important. If you don't do one of these steps correct, you will not be successful with your biopsy. Notice the young, my friend, the young Rajesh Puri sitting there. Rajesh was one of my best pupils, I must say. He was so dedicated, and I'm happy to see him here today. EUS guided biopsy, what we learned in the beginning, we didn't know the indication for this. So we had to think about indication. In the beginning, we thought submucosal tumors, really not very much on external lesions. And now it has turned out that this is much more frequent an indication. It is freezing right now. I'm sorry, but my computer is freezing. It is with great pleasure that I have accepted the invitation to give a talk on past, present, and future of EUS-guided tissue acquisition. So my disclosures, and shortly after I will tell you about the aim of my talk. First of all, a historic background seen from a personal perspective. I would talk about mainly the needles. I would talk about mainly the needles. Summary of results in the humans, stating that it was not for human use. The anatomy was equipment for FNA in particular. First, it was started with Wilson Cook, Denmark, in 1991. And in the beginning, we thought that long steel needles or long needles on plastic sheaths would do. But this is, we found out this was not correct. And we had a problem with the force translation. So we came up with the idea, sure that whenever cancer was seen, it was cancer. This was actually also the first book whatsoever written from the other early pioneers. And from that publication, we actually learned what the indications were. We weren't aware of that in the beginning. And we realized also that there were differences in diagnostic values depending on the lesions that you were targeting. We now know that there is a lot of indications for EUS-guided biopsy, staging of upper GI cancers and lung cancer. Today, we can do EUS-FNA in patients also that are scheduled for surgery. When this is set, and there are many of the publications doesn't show difference in results whether you do with or without 19 and 20 gauge needles with different levels, as you can see here. 25 gauge needle group, no surprise. Bigger needles take bigger bites. Then the third generation needles, the so-called crown cut needles. This is the 22 gauge Acquire needle. The length of tissue core biopsies per needle pass was significantly higher with the 22 gauge Acquire needle compared to the 20 gauge Procore needle. So there's no doubt that this needle takes better bites even when it is a smaller needle. There is also not very many at this time, but a few studies comparing the shark with the Acquire, and it doesn't really seem that there are differences. So I would say that crown cut needles take bigger and comparable bites. So, but this is the shark needle in submucosal tumors. Also here you see a very, very high diagnostic yield with the shark needle. The problem is cystic tumors, and what we have seen that cytology EUS guided sensitivity is like tossing a coin. 54% sensitivity with a pooled specificity of 93%. And it is something we have to improve upon. I just want to share with you one of our own prospective studies, which is now accepted in endoscopy in June 2020. This was a PhD study, a prospective single center study in 101 patients. And what we have experienced is, first of all, that we are actually able to get good micro histological samples out, and we're able even to subclassify these samples when it comes to IPMNs. Now you see the procedure in the right-hand upper corner. But the results have demonstrated that when comparing to cytology, the discrimination between mucinous and non-mucinous lesions is much better with the microbiopsy and the specific cyst diagnosis as well, compared to FNA cytology. And the technical success was very high, 94%, and clinical impact around 12%. So I think this is a procedure which has come to stay. So coming to future directions, now we have possibilities with good needles, with FNB needles, with microbiopsy forceps to get tissue out. And we are able to perform molecular analysis, both genomics, whole genome sequencing, transcriptomics with RNA sequencing, and proteomics. I think this is the future for EUS-guided tissue acquisition. And we already have some preliminary results with this. This is a meta-analysis showing that overall KRAS mutation testing applied to cases that were inconclusive by EUS FNA reduced the false negative rate by 55, by half, with a false positive rate of 10%. And we are also now working on this, as you can see in the publication below. There's also a randomized study, a very good study actually, between EUS FNA and EUS FNB, showing that the 22 gauge EUS FNB needle provide more histological core tissue and adequate nucleic acid yield compared to a 22 gauge EUS FNA needles. So I think FNB needles should be preferred. This is our own study, preliminary study, culture of organoids from FNB samples. I know there are other groups working on this as well, but the goal with this is, of course, to viability test organoid cultures prior to surgery from individual patients with different chemotherapeutic regimens. So coming to my conclusion, tissue is the issue. EUS-guided FNA has undergone 30 years of evaluation now. A wide range of established indications exist, including staging as well as primary diagnosis of a variety of lesions. EUS-FNA and EBUS-TBNA can near to fully replace mediastinoscopy in lung cancer staging. Standard EUS needles are not inferior to a reverse bevel needle when it comes to sensitivity and harvesting of core tissue for histology. New crown-cut core needles improve significantly histological tissue harvesting from solid lesions. EUS-guided microbiopsy from cystic pancreatic lesions improves significantly diagnosis and subclassification of cystic pancreatic lesions. An unexploited potential for obtaining material for molecular analysis exists, and EUS-guided biopsy may in the future become an important method in tailored oncological therapy. Thank you for your attention.
So
is Dr. Peter Willman is online? Is Dr. Willman is there? Yeah, we did the pre-recorded lecture later on.
Okay.
Is Dr. Willman is online?
I don't think so.
So I think there is we can go to the next session. Thanks to all the chairperson